Hi, I'm Dr. Bill Whitehead, CEO of Therapy Appointment. I'm here today with Dr. Joshua Lennon. Dr. Lennon received his BS and MD degrees from the University of Miami and additional training in neurology and then adult and pediatric sleep medicine at the University of Tennessee Health Science Center. He currently lives in the Memphis, Tennessee area, where he is the medical director for an American Academy of Sleep Medicine accredited sleep center. He's also assistant professor at the medical school there. Most critically, he is a die-hard Red Sox fan. His website, wellrestedmd.com, is a place where you will find podcasts on sleep and sleep hygiene. Well, Dr. Lennon, that's a resume that any mother would be proud of. I think you've been appropriately vetted now as an expert on sleep. I want to start off with a question that's always puzzled me. If I were going to design a human being, one thing I would not put in the design is to incapacitate him completely, make him vulnerable to predators for fully 1/3 of his life. So what is the purpose of sleep?
Yeah, there's an unsatisfying tautological answer, which is that the purpose of sleep is that it's a requirement for life, and it's required because it's purposeful. So, if you go back billions of years, or the first life forms are these photosynthetic cyanobacteria, and if they are going to make energy and derive utility from sunlight, the sunlight is only there for a certain period of the day and then it disappears. So they can really only be active for one portion of the solar day and then inactive for the rest, waiting for the next time that the sun circles around again, but they have access to that resource. And so we see this retained in basically every branch of the tree of life, that there are periods of rest interspersed between periods of activity. Now, in terms of human health and well-being, we can certainly see benefits of it derived from problems that we see in the absence or the inadequacy of sleep. In medicine, we tend to use a pathological model where you break something and then you see what happens, and that's how you understand what the purpose of that thing is. And in sleep, we see that when people have inadequate or poor quality sleep, that there are consequences to all modes of health and well-being, from the quality of our thinking, certainly our degree of alertness, to metabolic health, to immune health. Basically, every single organ system in the body can be detrimentally affected in the absence of quality sleep. And so that supports this notion that the purpose of sleep is to keep us going, that it is really required. But that's not a very satisfying answer.
Well, as good as it gets, perhaps. Well, I know in graduate school, when I went there back in the dark ages, they talked about two different categories of sleep disturbances. They called them dims and does. I don't know if that's still a set of terms, but do you know what I'm talking about, that distinction of two categories?
Yeah, I never heard these categories before, but I think it kind of makes sense. We tend to see the two be mixed up considerably. DIMS being disorders of initiation or maintenance of sleep, and does or do's disorders of excessive sleepiness. And really, they can be two sides of the same coin, which I think is one of the reasons why you see for sleep societies, whether it's the American Academy of Sleep Medicine or the Behavioral Sleep Society, this iconography of the yin-yang symbol, where when we look at sleep health, it really cannot be taken in isolation, but really only in concert with the white of wakefulness, that the two complement each other and really need each other. And so often disorders of initiation or maintenance of sleep fundamentally have to do with how we spend our wake time. If something is happening intentionally or unintentionally during wakefulness that is contributing to difficulty with sleep starting or continuing sleep. And then disorders of excessive sleepiness, which is a problem during wakefulness, really come down to either inadequate or poor quality sleep. So it really is the sleep problem causing the sleepiness during the day, and it is problems, behaviors often um, innocuous during the daytime, during wakefulness, that are contributing to disorders of maintenance or initiation of sleep. So the two, it's you can isolate one or the other, but they really do complement each other, and they really do need the whole yin yang model, the white activity of wakefulness and the pitch black dark rest of sleep, because one or the other can go wrong, and then influence its counterpart to also become disordered as well.
There's an old saying that if you give a kid a hammer, everything begins to look like a nail. And I'm afraid that's true of therapists as well, that in a rush to provide some psychological treatment for a sleep disturbance, they may overlook some medical issues of which a sleep disturbance is just a symptom, perhaps to the detriment of their clients. What are some of the medical issues that do present with sleep disturbance as a presenting symptom?
Well, first of all, I'd say that there's nothing wrong with rushing to alleviate suffering and pain, and so I don't think there should be any guilt on the part of therapists who are trying to do the right thing by their clients. There are several categories of medicalized issues that can present with sleep symptoms. One of the classics would be issues with thyroid function. If the thyroid is underactive, then people can be much more fatigued. They can feel excessively tired. They may even have difficulty falling and staying asleep because of their lack of activity during the daytime. If somebody has a hyperactive thyroid, then that can also manifest as difficulty falling asleep or staying asleep, feeling almost over aroused during the daytime. Medications are certainly probably the largest category of medical problems that are really iatrogenic, that can lead to sleep difficulty. If you look at any list of potential adverse effects of any medication, chances are you're going to see either sleepiness or insomnia on the vast majority of them. Just because it's a medicine or a medical problem causing a sleep issue doesn't mean that alleviating some of the symptoms, even if you don't fully appreciate what the underlying trigger is, there's still great benefit to doing something like that.
And how about psychiatric or behavioral disorders? What are the primary disorders that have a sleep disturbance as a symptom?
Yeah, it's been a while since I've thumbed through the DSM-5, but I'd say probably the two biggest categories that come to mind would be mood disorders and anxiety disorders. So one of the requirements for, say, something like depression would be excessive fatigue, lack of energy. And there's a distinction, but it's often not fully appreciated between, say, fatigue and feeling tired, exhaustion, and actual sleepiness. One is a sensation of I don't have the energy to keep on going, and another one, sleepiness, is really if there's a couch or a bed, I'm out. Whether I really feel tired or not, that there's a pressure pushing me towards sleep. And with depression, major depressive disorder, there really is that fatigue or lack of energy that is one of the main issues that can present. In terms of anxiety disorders, certainly difficulty with initiation or maintenance of sleep is at the core of what many people suffer with for generalized anxiety disorder, not necessarily, say, some of the phobias. For something like PTSD, certainly nightmares become a major part of the suffering that they experience. So understanding how dreaming and nightmares can fit into to post-traumatic disorder, I think that can certainly be one of the presenting symptoms. And then often with issues of substance use disorders, that there can be symptoms of difficulty falling asleep or staying asleep or waking up too much, or excessive sleepiness during the day, depending on the individual substance that's being used or misused. But that's not really one of the core components of presenting symptoms of something like substance use.
Okay. We hear a lot about sleep apnea as a cause of both daytime sleepiness and obviously sleep disturbance. We hear about it more and more, and with the invention of the CPAP machine, I kind of wonder, is that why there's more of an emphasis on it these days, because we finally have a treatment? Or is that really a primary cause of sleep disturbances?
Yeah, so for the sleep physician, their hammer is the CPAP machine, and so everything looks like a nail now. I'd say it's not wrong to see the overabundance of attribution of problems to sleep apnea. It is becoming increasingly clear and increasingly evident in the peer-reviewed literature that sleep disordered breathing is much more prevalent than previously appreciated. The assumption, has been, for a couple of decades that it's there, it's a problem, it needs to be addressed, but it's not really all that widespread. But as we, utilize our tools more effectively and, stop screen everybody with a questionnaire first, that we find that the prevalence is much more disturbing than previously thought. There is now a lot of emerging data on insomnia specifically, that insomnia is one of the main presenting symptoms of sleep disordered breathing.
Another suspect du jour is blue light. We've been hearing about that a lot lately, especially people staring at their iPhones as a part of their bedtime routine. I'm unfortunately one of those people. Is that just kind of a red herring, or the suspect du jour, or is there some solid research behind that blue light issue?
I think there's a fad about blue light because we have technology about it. Uh, the truth is, yes, light is extremely important for sleep and wakefulness, and it's really all spectrum of visible light can have this effect. However, there is a peak frequency, and this is 470 nanometers, which is what we see as bright blue light. And so that has a more potent effect on inducing wakefulness, say, than the red end of the spectrum, or greens or purples or other parts of light. Now, why we see this being so trendy is because now, in the last few years, there are filters, technological filters in our devices where we can weed out that part of the spectrum, and so everything looks kind of orange on your screen. And because now there's technology for it, now everyone is a lot more enthusiastic about light. But to me, it's sort of the wrong approach to the problem. And so the answer is not put a new filter on your phone or wear some goofy looking glasses. The answer is stop staring at light when you should be sleeping. There's a much simpler way of addressing the problem. You don't need to build some technology. It's just put down the screen.
Great idea. Back in graduate school, again, back in the dark ages, I was told that 95% of sleep problems can be traced back to sleeping pills. Now, I suspect they made up those statistics on the spot, but is that a serious cause of sleep disturbances, the over-reliance on sleeping pills?
Certainly, but I think you have to appreciate, why we run into this problem in the first place, which is that people are suffering. They don't feel like they're getting the sleep that they deserve or want or need. And when they finally build up the confidence to tell somebody else that, I'm hurting and I need some help, that depending on who they tell, they're going to get different responses. And in medicine, we are trained to prescribe medications. A surgeon is trained how to operate, and all the rest of us are trained how to prescribe. And so if somebody comes to us with a problem, our first and almost always, what we're going to respond with is prescribing a medication. And so getting into this problem has a lot to do with how we are trained to respond to these kind of issues in the first place. One of the problems that we have is that the medications are pretty harmful for the most part. Most sleeping pills come in the form of sedative hypnotics, and these are medications that act on the GABA system in the brain, the same system that alcohol operates on. Now, when we think about the neurochemistry of sleep, it is complex. And one of the problems of overemphasizing one of these chemicals in the brain to the detriment of the rest is that it starts to disturb normal sleep. That rather than having the ebb and flow of these different chemicals being a little bit more active and then less active, then more active again, Instead, if you just have them, turned up to 11 all night long, it chemically prohibits the brain from achieving normal sleep.
There's an old saying, no one ever died of insomnia. They just wish they would. But lately, I understand there is some research that shows that there are some significant medical issues that can arise from insomnia. What are some of those issues?
So, there are a few ways where this can be problematic. One would be undiagnosed or unrecognized sleep disordered breathing presenting as insomnia. And even mild sleep apnea comes with it an increased risk of mortality, overall mortality, and especially cardiovascular death. So that could be a component of it. But the main line of research, this comes from Julio Fernandez Mendoza and his team at Penn State. Pennsylvania is the mecca of insomnia research between Penn State, UPenn, and University of Pittsburgh. I mean, everyone who's involved in insomnia, that's the place to go. And Julio, what he and his team have found out is that there are different categories of insomnia that they found in their large cohort there. There are individuals with an insomnia complaint, so a subjective experience of difficulty falling asleep, staying asleep, not feeling rested upon waking, and yet their total amount of sleep is within the normal range. So maybe they have to spend 12 hours in bed to squeeze out 7.5 hours of sleep. So the duration of sleep is normal, but the experience is terrible. There are individuals who have no complaint of insomnia. I don't have difficulty falling asleep, staying asleep. I feel okay when I wake up, but I'm only getting 5.5 hours of sleep a night. So I have short sleep without insomnia. And then there's the combination of the two, when I have the experience of difficulty falling asleep and staying asleep, not feeling rested upon waking. And on top of that, I'm only getting under 6 hours of sleep at best. And that's the category where we see the risk. So having insomnia itself does not seem to add any significant risk, say for mortality or high blood pressure, poor outcomes, morbidity and mortality. But the specific category of individuals that have insomnia and on top of that are getting an insufficient amount of sleep, they have a much higher risk of death and disease compared to individuals without the insomnia complaint, but the exact same amount of sleep. So it's not that just getting short sleep is a problem, which it is, but when you have short sleep plus the complaint of insomnia, that really is the deadly combination.
I've also heard of some research about Alzheimer's being connected with sleep disturbance. What do you know about that?
Yeah, this is a story that has come together over the last 20 to 25 years or so. And while the exact mechanisms haven't really been worked out, we have multiple lines of evidence all converging on this central fact that the largest risk for Alzheimer's specifically among all the dementias really has to do with sleep and circadian health. Part of this comes from the discovery of these two proteins that build up to toxic levels in the brain with Alzheimer's disease called beta amyloid and tau. And when they build up to such an extent, they trigger an inflammatory response. And it's that inflammation that actually destroys the tissue of the brain, causing dementia. But the reason why these proteins build up in the first place has to do with the lack of appropriate clearance. So it turns out that in every single one of us, every morning when we wake up until the time that we go to bed that night, every day that we are awake and our brain is active, these proteins are building in concentration across the wakeful day. In some cases, almost doubling from the time we wake up until the time we go to bed. And normally what should be happening is that when we fall asleep, we're now clearing them out, that they build up, they're a metabolic waste product, if you will, of being awake. And then as we sleep, we're taking out the trash, but we're getting rid of all that built up waste and we start clean the next day. But if you have some disorder of sleep, whether you're not getting enough sleep or you're not getting enough of a specific stage of sleep, called slow wave sleep, the third stage of non-rapid eye movement sleep, we lack the ability to clear away enough of these proteins at a time. And so every night that we get insufficient sleep or insufficient quality of sleep, these proteins are not getting cleared out. And so we start the next day at a higher level than the day before. And then we build up and we clear out a little bit. And then the next day we're starting at a higher level. And night after night after night, we continue to build a concentration of these proteins. And that leads to further accumulation into plaques and tangles that end up triggering these inflammatory responses. And that's what leads to problems.
CBT, cognitive behavior therapy, or I think you mentioned cognitive behavior therapy for insomnia, CBT-I, is emerging as the primary psychological treatment, or at least the one that's got the most proof behind it. What are the major components of this I think many of our audience may be familiar with the basic concepts of CBT, but what is emphasized in CBT-I for treatment of sleep disorders?
This is this cannot be emphasized enough. CBTI is not just the best psychological treatment, but it is the best treatment for insomnia. And this has been shown over the last several decades. It depends. It doesn't depend on how it is performed, whether it is one-on-one or with the group, whether it's done just over the telephone, whether the patient has medical comorbidities, whether they're pregnant and nursing, whether they have mental health comorbidities. It doesn't matter if they're older or they're younger. It doesn't matter if it's done digitally. That every way that CBT for insomnia is performed in every population studied so far, it is the most effective treatment for insomnia. And so now this is the gold standard treatment as recommended by the American College of Physicians and the American Academy of Sleep Medicine. CBT-I takes sort of the core of CBT and just kind of twists it, to target towards insomnia. The behavioral part is really sort of the easiest to understand for non-therapists. This really sort of takes the clues that we got from 1960s classic hyper-rational behavior research, but we're really trying to reframe the conditioning. So people that suffer insomnia often they'll try to squeeze out a little extra sleep by spending more time in bed. And so, for instance, if somebody says that maybe they get 7 hours of sleep, it might take them 10 hours in bed to achieve that. That they go to bed a little bit earlier because they didn't get good sleep last night. Their alarm goes off, but they don't have any obligations right now. So maybe they'll just stay in bed a little bit longer to try to get more sleep. And so we spend an excessive amount of time physically in the bed, spending less and less and less of that time actually sleeping. And so we start to condition ourselves to associate the physical bed itself, being in that space, with the act of not sleeping. And then on top of that, you now are associating this cognitive hyperarousal of I'm in bed, I'm not sleeping, and I don't like that. I want to change that. This is irritating, it's frustrating. And I know that when I don't sleep, I don't feel great the next day. And so now I start to ruminate about what's going to happen. And now we associate the bed itself, laying under the sheets, head on the pillow, with this act of suffering. And so what the behavioral component of CBT-I is to reframe that relationship with the physical space of the bed. And this comes down to a few key issues. Number one is don't spend too much time in bed if you're not sleeping. Number two would be to go to bed only when you are sleepy, not at a prescribed time, like you have to go to bed at 10. No, you go to bed when you are ready to fall asleep. Not tired, but sleepy. And that's where that distinction can become important. And then three would be to get out of bed if you are not sleeping. So let's say you get into bed, you fall asleep, and then you wake up for whatever reason at 1:45 in the morning and you can't fall back asleep. Well, the longer that you just sort of wait there, twiddling your thumbs, staring at the ceiling, hoping that sleep is just going to come to you magically, the longer you do that, the more you reinforce the act of being awake with that space of the bed. So if you're not sleeping, get out of bed. And then the fourth component of that behavioral therapy for insomnia is to get up at the same time every day. And this is to reinforce the circadian component to difficulties with sleep. When we think about and conceptualize sleep, there's really two main influences. One is our circadian rhythm, this natural 24-ish hour cycle that every tissue in the human body goes through, and trying to align our opportunity for sleep with that circadian rhythm. And the biggest influence on circadian rhythm is going to be exposure to light. And so if you expose yourself to morning light, you become active, you eat at the same time every day, you're much more likely to be ready for sleep at the same time every night as well. And then the other components really help to reinforce the other process, other influence on sleep, which is the homeostatic drive. This rubber band stretching more and more and more until it finally snaps back into place for sleep. So the longer that we've been awake, the stronger our drive to sleep is. And so that's really what the behavioral component is really trying to target. The cognitive component, which is much more difficult for physicians to understand or appreciate or execute, certainly. is to try to diffuse the arousal associated with not sleeping. And so part of this can be a little bit behavioral, which is engaging in relaxation techniques, whether this is yoga, progressive muscle relaxation, stretching, massage, something to physically relax the body. And then something to relax the mind as well. This could be any number of activities for journaling or writing, gratitude exercises. And then there are the cognitive exercises, like a thought record, challenging unhelpful thoughts, writing down your automatic negative thoughts and kind of rating them and seeing if you can challenge them and reframe them. So those kind of techniques also help to lower the degree of cognitive arousal. And when that is combined with the behavioral component, that really provides the best results. And we see, depending on the study, somewhere in the ballpark, about 85% of people have a significant improvement in their insomnia, or the insomnia is resolved from CBT for insomnia, which is a more robust clinical response than any other intervention ever tried. And so it's really the combination of the de-arousal techniques and relaxation, these other cognitive exercises, the behavioral reframing of how we interact with the bed, and then basic sleep hygiene recommendations. That combination is CBT for insomnia.
All right. I'm going to try to bring this close to home for you. Paint a picture for you here. The Red Sox are in the World Series. It's 11 p.m. You're watching on TV. Bottom of the ninth. Red Sox are down by 3. Bases are loaded, and this rookie gets up to bat. Very irregular batting history. Not much is known about him. A lot of complaints about his having been brought onto the team in the first place. So here you are, I imagine, in about the largest amount of arousal you personally could be in. But you got to get up the next morning at 6 a.m. How do you transition from that state of arousal to being asleep? What techniques could you use to get yourself down that hill most rapidly?
Yeah, so this was an actual experience. I'm a huge Red Sox fan because they won the World Series in 2004 after the 86-year drought. And I'm sure a lot of people will be upset with me for saying this, but I frankly don't care if they win again. they won the one time, 86 years. My grandparents lived and died and never saw them win, and they won in 04, and so everything after that, it's all just icing. But that being said, I think part of it is to appreciate that you shouldn't let your sleep dictate your life. And so you don't want to be overly controlling about your sleep. And part of that means that we understand that some nights we're going to get good rest and some nights we're not. That, when it's something like, once in 8 decades of baseball, that might be something worth losing a little sleep over. It's not a habit, it's not a routine, it's a one-time thing. I'm sure all of us have experienced either not getting enough sleep or pulling an all-nighter, whether it's the first time at a sleepover party when you're a kid, or cramming for a test when you were in college. And we survived. It was not pleasant the next day. We were tired, but we were still able to get on with our lives. So that frame of mind, I think, is really important, because it's really easy. It is incredibly easy to get stuck in rumination, that because I was so excited about this, or because I stayed up later than usual, that now everything is going to fall apart and tomorrow's going to be ruined. And because I'm going to get fired, and then I'm not going to have a job, and then I'm not going to have any money, and then she's going to leave me, and then and it's easy to spiral out of control. So I think the most important part is to appreciate that fact that sometimes there are bad nights, and that's okay. So one thing, if you are so excited because he hit the grand slam, if you actually write it down. So rather than say replaying that moment in your head over and over again, or just flip into ESPN and watching the replay on SportsCenter over and over and over again, actually writing it down, physically with your hand, not typing it in your phone, but physically with your own hand, writing something down like, I'm so glad that they won. Or did you see the way that that he took the turn on third base? That writing it down, that helps a lot. It helps a lot to diffuse. It helps a lot to wind down just from the act of writing. There are physical things that we can do. And so this is where techniques like stretching or massage, or one of my favorites of the progressive muscle relaxation, that in a span of a matter of seconds, that you can physically relax yourself making you in a much better position to be able to fall asleep and stay asleep. There are other physiological things that we can do environmentally to make ourselves more prone to fall asleep, especially after being hyper aroused. And so, cooling ourselves off, whether you take a warm bath and then air dry, or you just drop the temperature in the room, but just that environmental temperature change is enough to make us much more ready to fall asleep, even if we are still psychologically and excited about the events of the Red Sox winning the World Series again. So there are certainly ways that in the moment, in a matter of seconds to minutes, that we can really wind down relatively easily to get ourselves ready for sleep. But I think really the most important thing is appreciating that, if it doesn't go so well, if tonight is kind of rough, tomorrow might be a little bit difficult, but that's part of life. We'll be okay.
Well, thank you so much. How would a potential patient get in touch with you if they wanted to have a consultation with you or your clinic? And we'll put this on the screen as well.
So they can find me at my personal website, which is wellrestedmd.com. For my clinic, it is neurologyclinic.org. We are currently licensed in the state of Tennessee. So anyone in Tennessee, if you're not opposed to telemedicine, which is the new way of life in medical care, we can certainly take care of you. And so anyone within the Mid-South region, we see patients from Arkansas and Missouri and Mississippi and Alabama. So we do have a wide reach there, but that's neurologyclinic.org. And then I'm also affiliated with the University of Tennessee Health Science Center in Memphis, Tennessee as well. And you can find us there at uthsc.org.
All right. If they can't find you with all of those websites, they need a new browser. Thank you again so much for your wonderful information today that I'm sure will be of help to many of our therapists as well as their clients. Thanks again.
My pleasure. Thank you very much.